Rodondi.
Dear colleagues, dear Chairman, thanks very much for the invitation. I'm very sorry for the change in program and that I have to leave just after the talk, but we had a very urgent meeting with our direction for the merging of all hospitals in Bern this afternoon. I have to be there. I think there is some problem with the slide. Okay. So the title is the role of lipids and lipoproteins in stroke prevention. I don't know if we can make the slide a bit better. So as you all know, for cardiovascular disease and coronary heart disease are very clear data showing that if you reduce the level of LDL, you reduce the risk of coronary heart disease events. And this is particularly true for all the trials in secondary prevention. So as low as you go, as much as you reduce the risk of cardiovascular disease. It's also true for primary prevention. Also, if you look at it's a bit difficult to look at, but if you look at the change in the absolute risk reduction, it's a bit lower. So the absolute risk reduction is lower in primary prevention. So the net benefit for patient is lower, and so you need to treat also more patients, the reason why also there is more controversy for primary prevention than for secondary prevention. Let's go to the important issue for today, so the risk of stroke and cholesterol. This is a meta-analysis of all trials that have looked at the reduction of LDL and the incidence of strokes for primary and for secondary prevention. And as you see, there is a similar relationship between the reduction in LDL cholesterol and the risk of strokes that decrease if you further reduce the level of LDL. So a similar relationship as we find for coronary heart disease. What are the exact trial data? This is also a meta-analysis showing all the trials that have been done on the risk of stroke, either direct analysis or sub-analysis of large clinical trials. And as you can see, if you look at primary prevention, all these trials are primary prevention of stroke, you have a reduction of about 19%, a significant reduction of the risk of stroke. If you look at secondary prevention of stroke, so these different trials, you also have a significant reduction in the risk of stroke of about 18% in these different trials. So there is also now clear data showing that if you reduce LDL, you can either prevent stroke or prevent the recurrence of stroke. One point is also which kind or which intensity of lipid lowering do you need to use. There are now several trials comparing intensive lipid lowering with normal lipid lowering with standard statin therapy. Has been shown for coronary heart disease events, but now it has also been shown for stroke. So if you look at the top graph, this is for coronary heart disease events. So a further reduction of about 13% with intensive statin therapy. And if you look at the panel B, the panel A, was for stroke, and the panel B is for major cardiovascular events. So for both, you have a reduction for stroke about 13% and a bit larger for coronary heart disease event of 16%. One issue when you go to intensive lipid lowering, there are also some issues that the absolute risk reduction is smaller, so you need to treat more people to get an additional benefit using high-dose statin. And there is also, particularly for primary prevention, the issue of side effects. If you go to very high dose of statins, as you know, with 80 milligrams, there are some data now that there is an increased risk of muscle problem, particularly with simvastatin. There is a FDA warning not using as a first line simvastatin 80 milligram. One big issue for stroke is the risk of hemorrhagic stroke. Also, we have clear benefit for ischemic stroke. For hemorrhagic stroke, the data don't go in the same direction. So for primary prevention of stroke, there is a pattern of reduction, but non-significant in the risk of hemorrhagic stroke. For secondary prevention of strokes, there is a pattern going in the other direction of increased risk of hemorrhagic stroke under statins, which was particularly, which was also significant, assessed in 2 trials with a 70% increase in the risk of hemorrhagic stroke, which has made a lot of concern for this situation. What are the explanation for this risk factor for hemorrhagic stroke? It was particularly analyzed in the SPARKLE data. What are the factors that drive an increased risk of hemorrhagic stroke? And one is the treatment with atorvastatin was also in a multivariate analysis directly associated with an increased risk of stroke. This was a single statin use. It doesn't mean that atorvastatin doesn't work, but statin was also directly associated with increased risk of hemorrhagic stroke in this study. There are also the other risk factors that plays on the risk of hemorrhagic stroke, like gender, increased age, the fact to have already had an hemorrhagic stroke was also a risk factor. And one important factor on which you can directly play a role as treating physician is uncontrolled hypertension. As you know, it's very important to have a well-controlled blood pressure to decrease the risk of hemorrhagic stroke, and this was an independent risk factor to have an increased risk of hemorrhagic stroke. So this SPARKLE trial, so it was a randomized trial comparing atorvastatin versus placebo with a primary endpoint of stroke. So one difficulty, so for use of statin, you have a clear decrease in the risk of ischemic stroke, which is more common, but a slight increase in the risk of hemorrhagic stroke. And I think what should be the clinical attitude in these situations is a largely debated topic. So you should be cautious with statin, particularly in patients who have already had a recent hemorrhagic stroke because of this data showing an increased risk, and the fact that hemorrhagic stroke as an entry, even in the trial, was also directly a risk factor for having an hemorrhagic stroke. And I think in this situation, it should be decided on an individual basis. What are the treatment guidelines for dyslipidemia? You likely all know that. This is risk stratification, and depending on the risk stratification, different level of LDL. And there are, as you know, we have also particularly a lot of data for this patient with high risk, so the patient with cardiovascular disease, who have already a stroke, then we have a large number of randomized trials. It's important, and it's also explained why there is this debate about primary prevention, particularly if you go to low-risk patients. We have few studies in intermediate risk patients, but the big controversy is particularly in patients with low risk or very low risk, where there are some guidelines, but it's more based on an expert opinion than on a large number of trial data, because in this patient we have very few randomized trials. One point you likely know, but it's also important for the young ones to know, you should be cautious if you interpret lipid after an hemorrhagic stroke. Ideally, you should make a lipid panel just after the stroke, so in the first 12-24 hours, because after that, it's the same pattern that you have in the risk after an acute coronary event. So you have a very quick drop in the level of LDL, and then you can make a false interpretation that the patient doesn't have dyslipidemia. Also, the LDL is in fact increased. The new guideline, as you know, published by the European Society of Cardiology, is now the new target for high-risk patients to be below 1.8 for patients with cardiovascular disease, chronic kidney disease, and diabetes. The alternative is to decrease the LDL at least 50% in this patient. One limitation for the issue of stroke, it has not been formally validated for patients with stroke. What type of treatment should you give to patients to prevent a stroke? And unlikely in this field of stroke, the only significant decrease in the risk of stroke is with statins. Diet is not significant, a pattern of decrease, but not significant, also based on a few number of trials, but non-statins don't have an impact on stroke. So statins are the single medication that have been shown to decrease the risk of stroke. One issue in clinical practice, particularly for primary prevention, as you know, is the problem of side effect. The muscle pain, myositis is common, rhabdomyolysis is very rare. The elevation in liver enzymes, and as you know, in these clinical trials was very uncommon, but in clinical practice there are some data that it's more common than in clinical practice. One issue you have with all your patients, as you know, even people who have an event, there is a big issue with compliance over time. In this data, you have, for example, for patients after acute coronary syndrome, the 2-year continuous rate of adherence was only 40%. We don't have data on that in Switzerland, but I'm not sure we do better. So there is a major benefit of the coronary prevention after stroke. Statins are effective after stroke, but there is no evidence of benefit for other lipid-lowering drugs. As you know, there are several controversies remaining for this patient, either stroke or cardiovascular disease. So about combined hypolipemic therapy, we have no trial showing really an addition of adding a second therapy. Treatment of HDL, as you all know, is very difficult. We don't have an effective treatment for now. And the patient in intermediate risk is still a group with some controversy. So thank you for your attention. Thank you.